you, members of the Knights, for having me here again. Thank you to the man who played the guitar. I used to play the guitar at St. Matthew's years and years ago with little kids jumping all around when it was in the folk kind of season. But anyway, there's a reason why I'm able to, God has given me some ability to do something. I've been going to daily Mass for over 35 years. Everything comes from Christ. Everything comes from his action working in me. And Eucharistic adoration is a very significant part of my life also. So it's not me, but it's Christ who wants to work in every single one of us. The interesting thing is I am not an expert in the area of euthanasia, but I know where the resources are. And I also know that when we lose respect for the beginnings of life, for the human person at the beginning of life, it's that slippery slope where we always lose respect at the end of life. And we don't treat that person as somebody made in the image of God. So that's what I've watched happening in the last 35, 40 years that I've been involved in some aspect of pro-life work. Besides my 8 children, I'm very blessed. I will soon have 20 grandchildren. So I just found out about that last week, that we're having another one in 5 weeks, and we'll have another one in March. And that's from just 4 children married. And I do have to say one other thing, because I will ask you for your prayers for this also. I have a son in the seminary, so he's for St. John's in Boston. He's at St. John's in Boston, and I'd ask your prayers also for all of our seminarians and for priests who are so very much under attack these days, and that they will persevere in this coming climate that we're undergoing. Okay, so this is what I'm going to do. All of my resources in my talk are taken from those who are actually experts in the field. So I'm going to ask you a question. Have you raised your hands for a minute? I put a sheet out there as far as my resources go, and it's called Trusted Websites for End-of-Life Resources, okay? I also have a couple of books there, and I want to just go through these resources for a minute before I start. And if you've ever heard of them, raise your hand. And the one who has heard of the most of them will get a free book. So I'm hoping that at least I am going to be bringing you some significant information that you haven't got anywhere else. How many of you have heard of the Patients' Rights Council? Good, okay, keep that in mind, okay. How many of you have heard of a website called CatholicEndofLife.org? Pretty cool, huh? On the website CatholicEndofLife.org, you can actually access your own diocese information and what they have on their diocesan website. You can even access the 3 Beliefs document if you so choose to do that. Every single state is listed, and it talks about Catholic end-of-life care. How about lifetree.org? No? How about hospicepatients.org? How about, I know a number of you know this from the National Catholic Bioethical Center, okay? How about prolifehealthcare.org? So there's a few there that you've never heard of, and they're very, very significant. Every single one of these websites can answer any question that I can't answer because I'm not an expert, but I can give you these resources. Did anybody have 3? Anybody have 2? Anybody else have 2? Whoever had, all right, 2 people with 2, I'll give you free books in the back. And there are two great books. One is on pain control, comes from the Patients' Rights Council. The other is Midwife for Souls, probably the best book I have ever read on end-of-life care. Okay, so credit for all of the information I'm giving you in the talk comes from Rita Marker from the Patients' Rights Council, Nancy Valco, who writes for Hospice Patients Alliance, and there are more. So, I heard a talk the other night by Ovid Lamontagne, and he had a good opening line, and I want to share it with you. He said, "Opportunity is an invitation from God to do His will." Opportunity is an invitation from God to do His will. So I received an invitation to speak. It's a little bit out of my area of expertise, since I've worked mostly with pro-life in the area of women who are considering abortion and birthright. But we're the laity, and we all have something to share. And we have to rise to the occasion. I've heard some very good talks on end-of-life issues by lawyers, but yet I still haven't heard some of the specifics that, the Lord has enabled me to bring to you tonight. So I've had a lot of personal life experiences, and I'm going to work a little story in my talk. 2 of my family members have died young, in their 40s and 50s, one from ovarian cancer, my sister and another brother in his 50s. My sisters and my family and I took care of them up till the day of their death, basically. My sister was on IV medication till the day of her death. She was able to give herself an injection of morphine by pressing a little button. And 2 days before her death, she was up. She could get up. But she was kept very much pain-free by the morphine that she was receiving. And we were very privileged because those of you who are here who have been at the bedside of a dying loved one know what a privilege it is that God has given you to birth a soul into eternal life. How close we are to eternity. I also had a young infant child on life support who died even while he was on a ventilator when he was 5 weeks old. So I've had a lot of personal experience, and at the time I knew he was dying, and the fact that he was on a ventilator did not stop him from dying because his heart stopped, okay? My mother and father died, and we were able to take care of them up till the day of their death. And that's one of the benefits of having a strong Catholic family. We were pretty much all in agreement with everything, and it worked very well. So what's euthanasia? Let me give you a definition. In the Gospel of Life, John Paul II defines euthanasia as an action or an omission which of itself and by intention causes death with the purpose of eliminating all suffering. So let me repeat that. It's an action or it's an omission which of itself and by intention kills the patient for the purpose of eliminating suffering. There are some good Catholic moral principles that we don't hear about too often, but I'm sure you people have probably heard them. One is, we can never do evil to bring about good. If you go home and look in the Catechism, it's number 1753, and it's a rephrasing of that where it says, the end does not justify the means. So we cannot kill a person to stop his suffering. We get to the root of the suffering by treating the cause of it. And the suffering is oftentimes, of course, physical, but it's mental and emotional also. Just by suffering with those who are undergoing great physical suffering, you lessen their pain. The Catholic Church has a lot of good documents on euthanasia. In her Declaration on Euthanasia, Part 3, she states, in cases of extreme pain, heavy doses of medication may be used even if there is great risk of hastening death. The intention is pain relief. The shortening of life occasionally is an unwanted side effect. There's a Catholic moral principle that goes along with that. It's called the principle of double effect. Now, that's not the same as what we occasionally see happening as what's called terminal sedation, where I have heard instances of patients are given so much sedation that it actually causes them to die. The Catholic Church makes a distinction between passive euthanasia, or killing by omission, and withdrawing or withholding treatment that is futile, that is, it's ineffective, overly burdensome. She says, euthanasia must be distinguished from the decision to forego so-called aggressive medical treatment. In other words, medical procedures which no longer correspond to the real situation of the patient, either because they are by now disproportionate to any expected results, or because they impose an excessive burden on the patient and his family. But it says it has to be done when death is clearly imminent and inevitable. This is what I've seen as I've been at the bedside of a number of patients that have died, especially from cancer. They're able to eat and drink something up until a few days before they die, in most cases, okay? Then the body shuts down. The kidneys don't function well, and of course, any food or fluid you would give them would be burdensome at the time. My own mother asked to have some fruit for breakfast on the very day that she died. And when we talk about these terms, they often can be misunderstood or misrepresented, so we have to be very careful. We need an advocate. We'll talk about that in a minute. I have another document that I want everybody to pick up afterwards, because there's mass confusion that the administration of food and water, whether by natural or artificial means, to a patient in a vegetative state, which I hate the term, is morally obligatory except when they cannot be assimilated by the patient's body or cannot be administered to the patient without causing significant physical discomfort. This is from the Congregation for the Doctrine of the Faith, responses to certain questions concerning artificial nutrition and hydration. Here's what the Vatican says: the administration of food and water, even by artificial means, is in principle an ordinary and proportionate means of preserving life. It is therefore obligatory to the extent to which and for as long as it is shown to accomplish its proper finality, which is the hydration and nourishment of the patient. In this way, suffering and death by starvation and dehydration are prevented. The second question says, when nutrition and hydration are being supplied by artificial means to a patient in a permanent vegetative state, in quotes, may they be discontinued when competent physicians judge with moral certainty that the patient will never recover consciousness? The response is no. A person in a permanent vegetative state is a person with fundamental human dignity and must therefore receive ordinary and proportionate care, which includes in principle the administration of water and food, even by artificial means. I'm going to tell you a story, and I know that some of you will be able to relate to this story. My mother-in-law suffered a major stroke at the age of 50. She was completely paralyzed on one side, and she had 4 young children at home and 4 older children. She was in a coma for several months and then had very aggressive rehabilitation at the Spaulding Institute in the Boston area. Throughout the years, she was able to take care of herself, but as she got older, she started falling, and we took her into our home for several years. Because of some other changes, she ended up having to be in a nursing home. At the age of 87, she was in a wheelchair. She watched the Boston Red Sox. She talked with her friends. She played bingo. She went to Mass. One of the aides got her out of bed one day and did a transfer. And when she did that, my mother-in-law's femur fractured. She had a fractured femur. She was in excruciating pain. My husband and I were on vacation. One of the things that I heard was, and it was from a doctor, saying that this is usually the beginning of the end for a patient like that. This is usually the beginning of the end. She was given morphine, I believe. She did not have much to eat because they were worried that she could choke. Although one of the aides did try to feed her and give her stuff, she could swallow. After a few days, my sister-in-law called and said, "They haven't operated on Mom." Now, isn't that the ordinary thing that would be done when somebody would fracture their leg? You would operate on them. My husband and I came back from vacation. I went in to see her. I asked the nurse for a 50 cc syringe, and I gave her some water through the syringe, and she could swallow very easily. There was no doctor to operate on her fractured leg. But in the meantime of several days, her condition had deteriorated because she hadn't had much in the way of food or liquids. So the first thing that we had to do was find a surgeon who would put in a gastric feeding tube so that we could build her up for surgery to repair her fractured leg. And we did that. And we got a doctor who operated on her and inserted a gastric tube or a G tube, which is a very, very simple procedure. It was done in 20 minutes. Now, you often hear that a feeding tube is extraordinary means, okay? And my husband just pulled something off the internet for me before I came here, because we'll talk about living wills in a few minutes, but the Title 10 Public Health section, it's about written directives for medical decisions. It's the laws of New Hampshire, where they recognize the right of a competent person to make health care decisions. It covers what we would call a durable power of attorney, or it covers what we would call living wills. Look at what it says on the state statute about life-sustaining treatment. It says life-sustaining treatment includes, but is not limited to, the following: medically administered nutrition and hydration, mechanical respiration, kidney dialysis, or the use of other external mechanical or technological devices. Life-sustaining treatment may include drugs to maintain blood pressure, blood transfusions, and antibiotics. The living will that is written in our New Hampshire state statutes, this description, means a directive which, when duly executed, contains the express direction that no life-sustaining treatment be given when a person has signed this directive. It also says medically administered nutrition and hydration means invasive procedures, such as, but not limited to, the following: nasogastric tubes. Those are invasive procedures according to our state. Gastrostomy tubes, IVs, okay? Feeding and hydration. How are we going to get around this? We need an advocate. We need to have a healthcare proxy, obviously. But let's just talk for a minute about euthanasia and assisted suicide. Assisted suicide is rapidly becoming the law of the land, and I believe at this point there are 4 states in our country, Oregon, California, Montana, and another one, that have assisted suicide laws that have now been written. With euthanasia, the way to distinguish it is death would not occur without a third party, so somebody else actually gives the injection, okay? But for assisted suicide, on the other hand, if a person who dies performs the last act, assisted suicide has taken place. So it would be assisted suicide if a person intentionally swallows an overdose of drugs that has been provided by a doctor for the purpose of causing death. I just read something that you may not have heard about yet. MDs, our doctors who are supposed to protect us, are now giving themselves duty to die power over patients. This article comes from National Review, I believe, by Wesley Smith. Wesley Smith is affiliated with the Patients' Rights Council. It needs to be heard. Feudal care theory has just taken a huge step toward nationwide imposition with an official policy statement by the American Thoracic Society in collaboration with other medical and nursing associations involved with intensive care. It's a frightening document. The statement essentially creates a right of doctors and hospital bioethics committees to refuse wanted and admittedly efficacious life-extending treatment they prefer not to provide. It is like the sign over the restaurant door. We reserve the right to refuse service. This will profoundly affect those with disabilities, the elderly, and the dying who want to fight to stay alive. Think about this. Doctors are establishing the right to create a conflict of interest with patients by sacrificing their fiduciary obligation to each individual on the altar of other matters that should be of lesser concern, such as the cost of care, perceived societal betterment, personal disagreements with patient values, religion, or desire to live as long as achievable. The doctor's and bioethicist belief in the quality of life ethic. Make no mistake, the policy statement seeks to further the power of the technocracy by enabling Obamacare cost-benefit panels to make decisions allowing the loss of insurance coverage for efficacious treatments of a doctor or a hospital when they consider it potentially inappropriate. It is medical authoritarianism, the power of a doctor-imposed duty to die. Now, what's going to happen with that when we do have a durable power of attorney for health care? Yet the doctors are even seeking to override that and impose a duty to die. It's draconian. And I want to read you one other thing of interest. I'm sure you all have heard of the Hippocratic Oath. The doctors have taken as medical school graduates. Hippocrates was a Greek physician. He lived before Christ. He's considered the founder of Western medicine. Here's what it used to say and what the doctors tried to follow. With regard to healing the sick, I will devise and order for them the best diet according to my judgment and means, and I will take care that they suffer no hurt or damage. Nor shall any man's entreaty prevail upon me to administer poison to anyone, neither will I counsel any man to do so. Moreover, I will give no sort of medicine to any pregnant woman with a view to destroy her child. Now that was the oath that they used to take. Several years ago, my husband and I were at the graduation of one of our sons with a branch of who graduated from a branch of Tufts University, the Fletcher School. And I happened to look in the handbook that they gave out to all the graduating seniors, and I saw the Hippocratic Oath. And this is what it said. I will respect the privacy of my patients, for their problems are not disclosed to me that the world may know. Most especially must I tread with care in matters of life and death. If it is given to me to save a life, all thanks. But it may also be within my power to take a life. This awesome responsibility must be faced with great humbleness and awareness of my own frailty. Above all, I must not play at God. Really? This is the type of oath that medical students are taking now. This was written in 1964 by a man who was the academic dean of the School of Medicine at Tufts University and is used in many medical schools today. I'm going to go through a quick history of the Right to Die movement, talk a little bit about durable power of attorneys, and then give you some more resources, okay? How did this all come about? The living will is the oldest type of healthcare advance directive. It's a dangerous document. It actually gives power over your life and death to an unknown physician. Now, if any of you have been hospitalized, you know the minute you go in, they ask you right away, do you have a living will, or do you have a durable power of attorney? And they push it on you, almost as if you don't have one, they won't treat you. But that's not true. By law, you don't have to have one, by New Hampshire law, and they must treat you, okay? It's a dangerous one. It's a signed, witnessed, or notarized document called a declaration. Most declarations instruct an attending physician to withhold or withdraw medical interventions from its signer if he or she is in a terminal condition and is unable to make decisions about medical treatment. Since an attending physician who may be unfamiliar with the signer's wishes and values has the power and authority to carry out the signer's directive, certain terms contained in the document may be interpreted by the physician in a manner that was not intended by the signer. Family members and others who are familiar with the signer's values and wishes have no legal standing to interpret the meaning of the directive. Nancy Valco, writing this, I believe in the Hospice Patients website, said in the early 1970s, when I was a young nurse, and I can attest to the fact that this is how it was, we had never heard of a living will. When a patient was confused or comatose and appeared to be dying, we discussed such possibilities as a do not resuscitate order. Again, that's a type of advance directive, by the way. Often aggressive and useless treatments were discouraged because such measures were considered futile. But one thing we didn't do was to offer to withhold or withdraw treatments like antibiotics or feedings to cause or hasten the patient's death. This all began to change with the advent of the living will and the increasing acceptance of the newly discovered right to die. The living will was originally invented by two groups in 1967, the Euthanasia Society of America and the Euthanasia Education Council. They, of course, have changed their names, and if many of you are probably familiar with the Hemlock Society, they've changed their name to Compassion and Choices. Sounds so wonderful, you know? But it's a national right to die organization. But something slipped in along the way. Now the right to die mentality has so thoroughly permeated the healthcare that even Catholic medical ethics committees discuss futility guidelines designed to overrule families or patients who want care continued when a patient is deemed to have a poor quality of life. Let me continue with Mary's story for a minute. We finally were able to find a surgeon who operated on her fractured femur. She was on a ventilator. She did have trouble weaning from the ventilator. She was 87 years old. But there were very few in the hospital that were willing to kind of push to get her off the ventilator because she was 87 years old, and this is the beginning of the end mentality that we see. Now, this was another Catholic institution that she was in. Was she suffering? Yes, she was. Were we suffering with her? Yes, we were there with her. Ultimately, she had to have a tracheostomy, and she had her G-tube. And over the last 2 years of her life, perhaps, she never was able to eat or drink or talk again. And yet, prior to that, she could do everything. She could even walk with a special cane. But what happened with my husband and me? One day, someone from the ethics committee came down to talk to us. And she said, "Why are you letting her suffer?" And I said, "Because she's not dying." The implication was, take out the G-tube. What was going to happen? She would then die from starvation because her family was letting her suffer. This is in a Catholic hospital. You have to have an advocate, and thank you, Lord, that my husband was that strong advocate, because they push and push at you, and it doesn't stop. When I took care of patients that were dying, what did we give them at the end? We gave them ice chips. We gave them mouth care. We gave them sips of water until they could no longer take a sip of water. We gave them appropriate pain medication. I'm going to switch gears a little bit. So what effect has this right to die movement had on the individual person, the sick and the disabled, and the handicapped and their families? The right to die, and I bet most of you have heard this from your elderly family members. The right to die has led to the feeling that one has the duty to die. A man named Nicholas Tonti Filippini speaks to the ways in which laws permitting euthanasia take hope away from those who are chronically ill. Now, Nicholas is an Australian bioethicist. He's the associate dean, or was the associate dean and head of the bioethics at the John Paul II Institute for Marriage and Family in Melbourne, Australia. He suffered for almost 4 decades with and he was permanently dependent on hemodialysis. He said, speaking from his own experience as a husband, father of 4, and a teacher whose adult life was marked by chronic illness, Nicholas describes how isolating illness and disability can be and how difficult it is to maintain hope. The fear of being a burden is a major risk to the survival of those who are chronically ill. He adds that if euthanasia were lawful, that sense of burden would be greatly increased, for there would be even greater moral pressure to relinquish one's hold on a burdensome life. I heard Pope Francis just make a statement also. He said the elderly are thrown away because they don't produce. Our society is becoming utilitarian. Nicholas also says, for several years until I objected, I received from my health insurer a letter that tells me how much it costs the fund to maintain my health care. I dreaded receiving that letter and the psychological reasoning that would seem to have motivated it. The fear of being a burden is a major risk to the survival of those who are chronically ill. Okay, so this is what we have to do. We have to homeschool ourselves. I didn't want to get up here and read a whole bunch of definitions for you, but I wanted to get you the resources that you would need to institute your own durable power of attorney for health care. And I have some resources out there. I have a document that will give you 3 particular websites where you can go to download a document, okay? Which is a durable power of attorney for health care. You must have an advocate, but even with that advocate, you're going to have to push. You're going to have to be strong. You have to become knowledgeable. For those in ministry, people will come to you expecting that you will have the answers. I actually had a very well-known priest say to me, "Oh, Jackie, they told this person that had cancer that she needed a feeding tube or she had some medical. But that's such a burdensome treatment to have a feeding tube inserted or a G-tube." So as priests and deacons, you have to become knowledgeable about these issues. What about comfort care? This is a word that has many meanings to people. The doctor or the nurse will tell you in the hospital, we're just going to keep your mom comfortable with medication. I had a friend whose mother was dying, not of cancer, but she was older. She was in hospice. She had no IV, they withdrew the IV. She had no fluids, and she had a raging urinary tract infection. And they didn't give her antibiotics. That's considered, in the hospice, as an extraordinary care. But it isn't. Antibiotics are now being withdrawn from patients, as well as food and fluids. So are blood pressure pills. But an antibiotic for a raging urinary tract infection is going to keep a patient more comfortable. She was very disorientated, as the elderly often are. So these are some of the abuses. This is why I've given you 2 websites out there, which is hospice care, and another one, which if you read these things, you will actually see what's going on with hospice care. It should be wonderful. The palliative care should be to make them as comfortable and have their family around and provide them from what they need, but it is being infiltrated with the mentality of the secular culture in certain places, so you have to be on your toes. So what you need a durable power of attorney. And before I end, I want to share with you one other thing to be warned about. If you go on the Patients' Rights Council website, which I'm going to give you, that is one of the resources where you may download a protective medical power of attorney. It's called a PMDD. The information is out there, okay? You can download it. They ask for a donation of $15, and this is something that you can use. But there is another document that's coming, it's becoming prevalent, and it's called a POST document. Have any of you ever heard of it? It's 2-sided. This is very, very dangerous. It's called Physician's Orders for Life-Sustaining Treatment. They'll be posted on many people's charts in a bright color, fluorescent color, right on the front of their chart. It's full of just checking things right away. Checking things in advance that you may not need 5 years down the line. And it becomes a permanent document on your chart. It's very dangerous because the doctor will look at this, the nurses will look at this and override anything else. So I want you to be aware because you're going to be hearing about POST documents. I want to finish up with just a little bit on redemptive suffering. The Year of Mercy is coming up. It's starting in December 8th, and it's going to go till the Feast of Christ the King in 2016. And we are going to be the recipients of abundant graces during this Year of Mercy. We may be called to spend long hours at the bedside of Jesus because Christ comes in disguise, doesn't he? Look around you. Many of you have been at the bedside of Jesus. But you're suffering with them. Not only is the patient who is ill suffering, you are also suffering. That's called compassion, to suffer with. And Christ not only redeemed us from sin, the power of sin, he redeemed suffering, and he gave it a value. Mother Teresa, when she was alive, started a particular society called the Society for the Sick and the Suffering, to show those people who felt that they could contribute nothing to anybody how powerful was their suffering united to Christ on the cross. And we all know how our mothers used to say, offer it up. But when my mother said, offer it up, I didn't quite know or get the connection. But I would bet in this room, in this church, sorry, Jesus, that many of us have family members or extended family members who have left the church and left the practice of their faith. And Christ needs our help to win souls. And we're going to be called on to sit with those who suffer. We could make a ministry out of that just by going into a nursing home, by going into a hospital. Be willing to suffer with others, because what does every heart long for? Every human heart longs to love and to be loved. When you sit with somebody and they know they are not a burden, they're pain lessons. There's a wonderful scripture verse. It comes from Colossians, chapter 1, verse 24. It says, "Even now I find joy in the suffering I endure for you. In my flesh I make up what is lacking in the sufferings of Christ for the sake of his body, the church." Well, what's lacking in Christ's sufferings? Our cooperation, our joining in his mission, our accepting the cross. This is extraordinarily powerful. It is an extraordinary privilege to suffer with Jesus Christ and with our loved ones. There is definitely a hidden joy, even with the mixture of the pain. Because I believe on the other side of eternity, what we don't see now, we will see. Those who, because of the graces, one, will live one day with Jesus. We could do an entire talk on redemptive suffering, but here are a few things you can do during this year of mercy. You can offer up some voluntary penance. You can educate yourselves by taking some of the resources out back so that you can then educate others. These are spiritual works of mercy. Instruct the ignorant, it says, right? We need to understand suffering love. It's a fragrant offering to the Lord. And I'll close with this story of my own mother's death. My sisters and I were standing around her bed praying. One of my sisters wasn't there at the time. She was in another room. My mother had only a few hours before asked for some food, but all of a sudden something changed. It was almost as if she were in the birth pain. She started to get agitated. Then all of a sudden, I realized that she was dying. And I said to run and get my other sister. We were praying the Divine Mercy. My mother tipped her head backwards. She opened her eyes wide, and she was looking at something. It was as if it was a vision. She was conscious of something else, and it was a most beautiful death. One of my sons had a friend. He was a baptized Catholic, but his family had never brought him up with much faith, although he had faith and tried to follow it the best he knew how. One day, when he died in his mid-20s, I got this story from my son. Kevin kept saying, "I want to go home." He was in a hospital bed in his home. He kept saying, "I want to go home." And his mother and father said, "Kevin, you are home." He said, "No, I want to go home." And he kept trying to go out of bed, get out of bed to something in the corner. He also was probably seeing something. Christ wants to bring us all home. Pick up a copy of Midwife for Souls. It's about helping to birth a soul into eternity. I think I'll end with that. I have the resources out back for the documents that I was talking about. I hope that I've added a little something, but thank you all for listening to me. And that's it.